Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee, Dr. Adel Hamid, Ustazna Dr. Ahmed Abdelaziz, for this kind invitation. So the topic today is rotator cuff tendinopathy, and we will go through the pathogenesis and treatment option. So that's my disclosure, nothing related to the topic itself. So back to the history of rotator cuff tendinopathy, it's been described in 1872, and the name of calcific tendinopathy was given in 1952. So the rotator cuff tendinopathy is known as one of the most painful shoulder condition, and sometimes it comes with acute severe shoulder pain. The prevalence in the population itself, according to the literature, is 2.7 of the population will get a calcific tendinitis at one time. The prevalence is normally in the third, fourth, and fifth decade of life, and it's more common in women compared to men. It's more common in the supraspinatus than the subscapularis, and the least incidence is the infraspinatus. It's very painful, yes, we know that, but you have to know it's a self-limiting disease. And if you look at the long-term outcome of 10 years follow-up of a patient of calcific tendinopathy, it's been confirmed that it's a self-limiting disease. Whatever you do to treat this patient, at the end of 10 years, all will be equal and it's gonna be self-limiting. The most common question I'm receiving in my clinic from my patient, why I do have this calcific tendinopathy. And if you look at the literature and if you go through the pathogenesis of the disease itself, you will find that there is many theories, there is many proposals, but at the end of the day, nobody knows why this happened. We know very well that the tenocyte is, for a reason, converted to a chondrocyte, and calcification start to be happening, but why this happened, nobody knows. We know very well it goes through 3 stages. Stage 1 is the pre-calcific stage, where there is no symptom, no pain. The second stage, the formative phase, where there is mild or moderate dull aching pain, and the severe painful phase, which is the resorptive phase, where there is a lot of inflammatory process and ending up with with acute severe pain. Diagnosis is very easy if you routinely do an X-ray for all shoulder pain, and you can see it very clearly. The problem that if you go through the MRI, you will find a question which is also is very common. Is this associated with a cuff tear or not? The problem that the reflection of the radiation by the MRI might give you a false impression that this cuff is torn. So let's go to the literature and see what is the incidence of concomitant associated rotator cuff tear with a calcific tendinopathy. If you look at this one, magnetic resonance imaging, they find that the patient with a calcific tendinopathy, they do have incidence of cuff tear in 23% only. And if you look at the control group, even the cuff tear is more common than the patient of a calcific tendinopathy. So it seems that they are completely 2 different kinds of pathology, and this is also confirmed by one of the publications coming from the Korean population. They find only 15% of the patients who have a calcific tendinopathy, they do have a concomitant cuff tear. This cuff tear might be partial thickness or full thickness. But the interesting point in this publication, it gives us a clue about which kind of patient usually have a cuff tear with a calcific tendinopathy. They are the elderly patient. Females are more common to have a cuff tear with a calcific tendinopathy, and patient with recurrent symptom, and the patient who have some hormonal disturbance also are more prone to have a cuff tear with a calcific tendinopathy. Management option on the top of the list is the conservative treatment, and we will see this is the gold standard of treatment of calcific tendinopathy: ultrasound-guided needling, shock wave, and finally the surgical option, which is the arthroscopic shoulder surgery. Let's start with the conservative treatment. The conservative treatment is the gold standard, as we said, and it's mainly resting, activity modification, physiotherapy, non-steroidal anti-inflammatory, and at the end of the day might end up with a subacromial steroid injection. Again, this should be the gold standard of treatment of any calcific tendinopathy of the shoulder. It's been proved in the literature, many studies prove that the outcome of conservative treatment is at least 70% of the patient will get better with only this kind of conservative treatment. What about if this patient doesn't respond to conservative treatment? Option 2 is the ultrasound-guided needling, which we call it barbotage. It can be done X-ray guided or ultrasound-guided. It's an outpatient procedure done under local anesthesia, so it's a simple one. What about the outcome? This is a 2 years prospective study, follow-up of patient underwent ultrasound-guided. They have a significant reduction in the size, but if you look at comparing this with ultrasound-guided injection of steroid, they almost the same, and also in the other literature with a systematic review, it's not a superior to conservative treatment. Extracorporeal shockwave therapy is one of the modalities, and also as a conclusion, it's not a superior to the conservative treatment, and it's not superior to the barbotage. What about this negative prognostic factor? This is a very important point, which patient is not doing well with the conservative treatment. They are the patient with bilateral calcific tendinopathy. If they do have it in the dominant arm, if they do have a medial extension of this calcific tendinopathy, they have a bad outcome, and high volume of calcification also is carrying a bad outcome. In terms of patient who has a persistent symptom, recurrent symptom, elderly ages, as we said, or hormonal disturbance. The arthroscopic removal, the main idea of arthroscopic removal is decompression of the pocket, removal of the calcification as much as you can. Repair of the cuff is a question, acromioplasty is another question. So that's how we do it. We go inside, do a diagnostic arthroscopy. Normally you find this hyperemia and hypervascularity of the cuff. Then we mark it with a needle. And normally I do it ultrasound guided, then go to the subacromial space with a small knife, open this pocket, and start excavating all the calcific tissue from the pocket. This is how it looks if it is in acute stage. And then finally, the question of dealing with the cuff. Shall we do a routinely cuff repair or not? I'm sure if you see this kind of tear which developed after removal of the calcification, I think all of you will agree that this patient is definitely for a cuff repair. The repair might be simple repair side to side. If you have a small tear, longitudinal tear, it might be a simple single row repair, or in such cases, double row repair is the treatment. So dealing with the cuff is very important. If you have a big cuff tear, you have to repair it. The other point, if you have medium size or small size tear, it's also advisable to repair it to avoid propagation of the tear, and it's helping you in early mobilizing this patient to avoid post-operative stiffness, which is very common in this type of patient. If you look at the literature also, this is a good comparative study between repair of the cuff versus no repair of the cuff. It finds that significantly better outcome in the patient who receive a cuff repair after removal of the calcification. Subacromial decompression as a routine on all this patient or not? The answer is coming from one of the comparative study which showing that those patients who didn't receive subacromial decompression, they do much better than the patient who received subacromial decompression. That's why the conclusion, don't do routinely subacromial decompression unless there is a reason for that, which is like osteophyte or bad nasty shape of the acromion, so you have to do it. So the two questions, which is very important, repair or not, definitely yes. Acromioplasty or not, definitely don't do it unless you have a reason for that. This is the outcome after you remove all the calcification, and that's what you expect from your patient with a good range of motion after receiving a good treatment. So the conclusion, it's a painful disease, but it's self-limiting. Conservative treatment is the gold standard. Ultrasound-guided needling or barbotage, there is a big question mark on that. There is no strong evidence. If you do a surgical treatment, try to remove as much as you can of the calcification. Do a cuff repair if you have a medium size or big size. don't do routinely acromioplasty unless there is a reason for that. Thank you so much.